for the invitation to talk. I'm Clay Cohen from Houston at Texas Children's. And this is timely because we recently had a case, which I'll walk through, of congenital TTP, and with the recent approval of recombinant ADAMTS13 for use in congenital TTP, there are a couple of questions that it seems that there are no answers to, really. So curious as to what other people think and what other people are doing if they've had the chance to use the medication yet. But the case is a 9-month-old male with a history of neonatal hyperbilirubinemia that required phototherapy, who presented with new onset bruising and petechiae in the setting of fever. And at his pediatrician's office, he was found to have thrombocytopenia. And this was kind of his course at, I don't know why my slide messed it up, so I'm sorry about that. But here's his platelet count is in blue, and then his LDH is in orange. So he presented with a relatively severe thrombocytopenia of 19,000 with a markedly increased LDH, as you see in acute TTP. The arrow is denoting the time that he got one plasma infusion. That was all the treatment that he received, 10 per kilo of plasma. Obviously, the peripheral smear had schistocytes, and his ADAMTS13 activity was 1%, and the inhibitor testing was negative. And clearly, he responded extremely well to the plasma and didn't require any other therapy for resolution of this acute TTP episode. And he only recently presented like a month ago. So we got, I mean, as we would have expected, we have preliminary information that the ADAMTS13 gene does have a pathogenic variant of it, which really at this point is more confirmatory than anything else. But it seems extremely consistent with congenital TTP. There's no one in the family that has this. He has an older brother that is healthy that we will evaluate. But in the background of this, in November, recombinant ADAMTS13 was approved by the FDA for use for treatment and for prophylaxis in congenital TTP in children and adults. So a lot of the conversation once we got through this was, what do we want to do going forward in terms of prophylaxis and other things? So the first question that comes up, you know, we get beyond this, clearly he responded very well to the FFP infusion and didn't need anything else to resolve that episode. So the first question is, to the parents and to ourselves, is do we want to start prophylaxis in this 9-month-old boy with congenital TTP? Are there any opinions on that? Do people start right away? Do you wait? Uh-huh. Mm-hmm. I don't have the specifics because we haven't actually gotten the result back to us. Our genetic counselor at TCH spoke to the company doing the genetic testing and was told that there is something there, but I don't know the specifics of, like, yeah. Would that, how would that impact your? Yeah. So, yeah, I mean, to us, I think there was a variant of unknown significance and then a pathogenic variant. But I mean, he has congenital TTP. Yeah, would that impact your decision to start prophylaxis or no? Mm-hmm. Mm-hmm. What's the youngest y'all have started someone, a child on prophylaxis? Do you know?
So we had no congenital patients until about a month ago, and now we have 4.
Oh, congratulations.
So we are in the process of trying to get recombinant approved, but I think our youngest patient is 3 and a half, 3, somewhere in there. Not.
That's a good question. I think it helps start people in sense, especially if they've had a classical presentation where they've had cranial stroke or the evidence of injuries to organ that is concerning enough that they have some practice. Obviously, classifications, but going forward, the question is, the recommendation to a lot of them come out of this opinion or not.
Yeah. Yeah, I think us as providers and the parents were pretty eager to start prophylaxis. He didn't have any end organ damage necessarily. He presented with, the labs and the cutaneous findings, but nothing else that was noted, which was good.
Just for background, question about how the recombinant is administered.
Yeah. Yes. So let's talk about that. So with, that just bleeds into what I was going to talk about next. I probably shouldn't say bleed. So this is the prophylaxis and treatment course that you use with plasma and for recombinant Adam TS13. So essentially for prophylaxis, both of these are IV. Obviously plasma is, and then recombinant Adam TS13 is also IV. They're both, the general recommended frequency is every 14 days. So it's pretty standard for plasma prophylaxis. And then for recombinant Adam TS13 prophylaxis, currently the package insert for the medication does state every 14 days. I think there are some ongoing questions that I'm gonna get to now, and then you can see the dosing strategy if someone does have an acute TTP event. So they're both IV, and that becomes a problem in such a young kid about routine IV access every 2 weeks. Quite frankly, this boy was already a hard IV access in the hospital and outpatient, so that's not a super encouraging sign, because then it comes questions about central line placement and things like that, which is an additional layer of difficulty. So then the additional questions about Adam TS13. So in the clinical trial that evaluated the effectiveness of recombinant Adam TS13 and congenital TTP, they didn't have any patients under 2 years of age in the trials. We happen to have at Texas Children's the representatives from the company come and give us a talk like the Monday after the weekend the kid came, and that was just coincidental, so that was nice. Yeah, so there's really no published data on children under 2 years of age, which sometimes we don't uncommonly deal with things like that in rare disorders and pediatrics. But that kind of gives you pause. There was a New England Journal case report about a family who had, the mom had 2 children die early in life from congenital TTP, and then they used the recombinant Adam TS13 in their next child who did very well. But beyond that, there's really not much evidence for use in very young children. Then the next question or issue that we're kind of thinking through is that the median duration when you're using the recombinant Adam TS13 infusions every 14 days, the median time that your Adam TS13 activity level is over 10% is 5.8 days. So that's less than half of the time that you're on recombinant Adam TS13 infusions, you're kind of like in the safe zone. And the pharmacokinetics dynamics in young children, they often tend to go through proteins and enzymes quicker than adults. Of course, we don't have data for that. So then it's a question of, should we really be administering it? If we're going to start it, should we be administering it every 2 weeks? Should we be administering it weekly? There's not much data to help with that. That's another question that came about. And it seems that when we asked the reps from the company about this, they did the every 2-week frequency because that what was traditionally done for people with congenital TTP, and it was kind of carried forward the prophylaxis frequency that they were getting before. And they did have some people that were getting it weekly, if that's the plasma infusion rate that they had been receiving before. So the frequency is a question. And the next question is dosing. So infants are small, and it is a weight-based dosing, and the vials come in 500 and 100 milligram vials. So the dose is 40 milligrams per kilogram. And for our patient, that put them at 300 to 310 milligrams. So are you going to way overdose them, or are you going to waste the medication? Yeah, these are all the questions that came up that we are debating through. I'm curious if anyone has any thoughts or perspectives or experience in answering any of these questions, especially in young children with congenital TTP. Granted, the medication's only been available for 4 months now, so I understand if there isn't a lot of experience. Yes, that is a spoiler because that's what we're doing. Yes, that so we are going to kind of do. So Shreya mentioned if you could do kind of check more frequent ADAMTS13 on a weekly basis. I think at Texas Children's we're fortunate because the assay is done on site, and the turnaround is about 4 or 5 hours. Not that we need to know day of necessarily, and if they're not having an event. But we are going to check weekly troughs, and hopefully, he never has another or doesn't have another episode. But if the troughs are routinely, less than 5%, if it's 1% in 1 week, I'm gonna bump the frequency up. Yeah. So I guess we think alike. I wonder why that would be. Yeah. Yeah.
What is a quick level to maintain? I think there's been a huge discussion in the community, especially with the recombinant also for new GDP in the future. 60%, 70, 80, and should close to 100%. We don't know. So if it's a week later, it is unlikely to be 20-40%, but more likely to do what you said. The study actually did weekly or every 2 weeks based on what the previously did. So there's definitely a lot of questions within the ASPHO blogs and also in terms of the frequency in younger children. And I think that's certainly a big question to ask.
Yeah. Yeah. So we did go forward, and the family agreed they wanted to start the medication, and our patient actually got his first dose last Friday. And we dosed strictly by weight, regardless of the vial size. While we were waiting and getting insurance approval, he did get 1 plasma infusion as a prophylaxis the 2 weeks prior. And then, like Shreya mentioned, we're starting by what the manufacturer recommends, the 40 per kilo every 14 days, and then checking out ADAMTS13 activities every 7 days, with the idea that if its ADAMTS13 activity is very low, less than 5% routinely at 1 week, I have a hard time not increasing the frequency to every 7 days rather than every 14 days. Another reason why we chose to go ahead and start recombinant ADAMTS13 is because the family, and I think we all were wanting to go ahead and start prophylaxis to avoid another event, kind of assume that it's an inevitability that he would go on to develop some sort of allergic reaction with so much plasma exposure and infusions that it just felt like an inevitability. And another reason why we chose to do recombinant ADAM-TS13 over plasma for a long period of time. Yeah. Has anyone else prescribed it? Yes, go ahead.
Are you getting infusions at home, in the hospital?
Good question. Thank you. So his first one was in the hospital, was in our clinic infusion center. And for the time being, it will be in clinic. Took a couple pokes to get him access. So I'm wondering realistically how long we're going to be able to maintain this without a stable central line. I think, yeah. So for now, for time being, it'll be in clinic. But then if we're having to increase frequency to every week, then we'll try to do it at home with home nursing or something like that. Yeah. Oh, yes. Sorry. Yeah. So the question was inhibitor development and time to inhibitor development to recombinant ADAM-TS13. I don't think there's any good data on that. In the clinical trial, there wasn't any report of inhibitor development to the product. Not neutralizing, I'm sorry. So I just think there's incomplete data to know. Obviously, the risk is there. It's a protein that the body doesn't make and is being exposed to it for a first time anew. Yeah, I mean, I'm the HTC director at Texas Children's, so I guess I think about like hemophilia through the first 20 or so exposures, that tends to be the highest risk. I don't know if that's the case with ADAM-TS13 recombinant. I don't know. I hope in a year or two I don't have an update on that, because then it would become a very challenging situation if you developed an inhibitory antibody to recombinant ADAM-TS13. Does anyone have any experience with that? Mhm.
Would giving it earlier, like infancy toddlers, decrease the risk of developing neutralizing antibodies compared to giving it for the first time in adulthood?
Yeah, question is like, does age of initial administration of the recombinant affect time to antibody development? Yeah, I don't know. I don't know if that is known either. I don't know if you. Yeah. Any other questions or comments? Yes. So the question is what to do about, he's in daycare, he develops a fever, the traditional anticipatory guidance is a fever, puts you at risk of developing an acute episode. You should come in and either get plasma or some form of the enzyme. I think the same is going to hold true. I don't know. So if he gets a fever, we're going to ask him to come in to have his platelet count and LDH and him evaluated. I don't know if we'll have the ability to give a dose of recombinant ADAM-TS13 rather than having plasma more easily accessible and just giving plasma in settings of an acute illness. Probably at the beginning, that's what we will do, especially because I think right now we're not prescribing many additional doses on top of the every 2-week doses. But yeah, that's a good question. I anticipate plasma for now, but I don't know if you have any thoughts. Yeah. Yeah.
Great questions of patients and dosing, especially the younger ones, going forward, challenges with IV access.
Yeah. Yeah. So hopefully I can give you all some update after we have, months worth of experience with this N of 1. But I know others are asking questions because I did see a question on the ASPHO chat board a couple of weeks ago. And sadly, there were no answers to the question about the dosing frequency and like the exact same situation. So hopefully once we all get more respective experience, we'll be able to help each other out a little bit.
That position was from Toronto, sorry, Canada, I can't remember exactly where. So they did a similar thing. We plan to actually check and monitor the activity levels drop and then decide what we need to do. I think one of the challenges in Canada is I can update on that.
Okay, cool.
You're right. I think the biggest question was, I think there's really definitely a room for a prospective study, at least some institutions with all of these patients. Because I think it's certainly learn a lot, even if it's not be more of a practice-driven question that we can ask. That is certainly a room for us to actually look at this, especially having institutions try to help.
Yeah.
How will the cost for the family look like?
Yeah, the question is about the cost of the drug. So they were very quickly signed up with help from the company on one of the copayment or patient care assistance programs. But I don't have an answer specifically about the annual cost to the patients. That information is always so hard to get, frustratingly so. Yeah, so I should have an answer for you, but I don't have a specific answer. Yeah, I don't know if others know the answer to that. Yeah. Yeah. Okay, thank you all very much for the questions.